Hello all, this is the quick PowerPoint slide on aneurysms that I promised you at the end of class the other day. I do apologize that it took me until Friday to be able to get it recorded, but here we are on Friday, and I will get this posted as quickly as I can. Let me get the slide to the right spot, and then I will share my screen. You don't have to see me doing the rapid fire click through the YouTube video and then perhaps have a seizure disorder start. So let's see here. Let's share my screen. Aortic aneurysm. That looks amazing. Here we go. So aortic aneurysms, and Margaret had talked a little bit about these because she's kind of an expert in them when we were together on Wednesday. But there's a few different ways that you can have an aortic aneurysm. And I know that when she was talking with us, she was talking about the true lumen, that true opening. And sometimes the intima of the artery gets broken down and you can have a false lumen in there. That can, when you were looking at the slides here, an aneurysm can happen in any artery, and you can have it a few different ways. Those false lumens tend to happen either in A or in B. C is actually a clot or a ruptured false aneurysm, sometimes called a pseudoaneurysm. Like I said, the aneurysms can happen anywhere in any artery. So they can happen in our cerebral, in our coronaries, and on our peripheral. And the book focuses on aortic aneurysm, simply because when we're talking, because it's part of the peripheral vascular chapters. So that's partly why it focuses on the aortic aneurysms. And if we have an aortic aneurysm burst, no matter where it's at, whether it's up here in the thoracic area, coming right, an ascending aneurysm coming right off of that aortic valve, all the way down through the body, it's kind of like a big hose carrying all of the different blood away from the heart. So if that thing goes, there's a big problem. So clinical manifestations of a thoracic aortic aneurysm, a lot of times they're asymptomatic. When they start to become problematic, it's kind of a little bit later, and they end up presenting a lot like our chest pain people in chronic angina, like we talked about in class. But they have a deep, diffuse chest pain, and that pain may extend into their interscapular area. And we can see where that pain would be coming from if we take a look at this diagram, because the aortic aneurysm starts restricting either the lung tissue, or it starts restricting the way that the heart can beat. Then that impairs oxygenation, and that's where this deep chest pain comes from. So the ascending aortic aneurysm comes right off of, this is the aortic valve right here. Let me grab it. Just give me flat. All right. So this right here is the aortic valve leading right off of that left ventricle. So manifestations of an ascending aortic or aortic arch problem include chest pain, angina, TIAs. These people can develop coughing, shortness of breath, hoarseness, or dysphagia. And if it presses on the superior vena cava, which it definitely can do, it will decrease venous return. It will create extended neck veins, distended neck veins, jugular JV distension, jugular vein distension, and it will also cause edema of the hands and of the face, but not of the lower extremities. An abdominal aortic aneurysm, so this is a third place for an aortic aneurysm, happens below the diaphragm. So that aorta passes through the diaphragm, and then it feeds the kidneys and it splits into the two different arteries that feed our legs. The abdominal aortic aneurysms, the AAAs, are often asymptomatic as well. Frequently, they're detected either upon a routine physical exam or when a patient's examined for an unrelated problem. So we found well, I didn't find it, but the medical team found my mother-in-law's aortic aneurysm. She has an abdominal aortic aneurysm. And they found it when they were doing a CT test for her gallbladder. So it's because of the imaging being what it is. She had imaging of her entire abdomen, pelvis area, because she was having some pretty nondescript problems. And they found a very, very small abdominal aneurysm that she doesn't necessarily have to do anything more other than monitor it. But if you can, the other thing that you can find upon assessment is you can actually hear bruit, which is you can hear the heartbeat in the tummy. When we're listening to the tummy, we're expecting bowel sounds, not a pulse. And you will actually be able to hear in a larger AAA, you will be able to hear a pulse when you're doing your auscultation of your bowel sounds. You can also sometimes, in people who don't have a whole lot of, people who have an extreme amount of body fat, though obese people who carry a lot of abdominal weight, you can't necessarily see it with those people, but you can see a pulsating mass right around the belly button, slightly left of the belly button. You might be able to see a pulse because that's the pulse of the aneurysm pushing the guts, and then the guts push up that periumbilical area. Fun fact. AAAs may mimic pain that are associated with abdominal or back disorders, especially like in here you can see that the AAA would be taking up a lot of space and it would be pushing on a lot of different things. If it bursts, it definitely causes back pain, and it causes the worst back pain ever, and then all of a sudden you have no vital signs. In addition to causing back pain, it can cause epigastric discomfort, so it can feel a little bit like heartburn. It can change bowel elimination because the aortic aneurysm is actually pushing the bowels, and bowels don't like to be touched. So they're very much like not huggers. And so they don't like being touched at all. So anything that's taking up their space, it makes them very, very finicky, and it'll either create an increased amount and frequency of elimination or a severely decreased amount and frequency so they can either develop diarrhea or constipation because of a AAA. The other thing you can get is intermittent claudication. Intermittent claudication is pain with movement. These people could spontaneously embolize any sort of plaque or any sort of buildup, and then that would cause blue toe syndrome, because what would happen if you had an aneurysm or a plaque get launched off from here, it's going to travel down and then into the feet and the legs until that embolus runs into something that's too small for it to get through, and it will clot off any sort of arterial flow to that particular limb that is distal from where it gets stuck. Rupture is the most serious complication of any aortic aneurysm, whether it be an ascending, a thoracic, or a AAA. And rupture with a AAA happens into the retroperitoneal space. Bleeding can be tamponaded, and otherwise it gets some internal compression by surrounding structures. And that can actually prevent bleeding out, which is exsanguination, and then death. You can actually bleed out and never have blood coming out of your skin, and this is one of the ways that you can do it. It manifests as severe back and flank pain, like kidney stone level, I'm going to give birth out of my back pain. And they may or may not have ecchymosis. This ecchymosis, Gray Turner is the person who got to name it, so it got named after them. But they may or may not have a reddened flank, so don't just look for reddened flank. If they're complaining of severe back pain, and they're having other problems with their vitals, get them some testing. If you have, that's for AAA, that was for an abdominal. If you have a rupture into a thoracic or abdominal cavity, that massive hemorrhage causes hypovolemic shock. Like they're bleeding out, but there's no blood coming to the surface through the skin. Most don't survive long enough to get to the hospital. And if they do survive, they need simultaneous resuscitation and immediate surgery. And then, like Margaret was saying, with that one case, those two cases that she had, that we collaborated on, it's a 50-50 shot of whether you're going to be able to make it out of surgery and make it through successfully. That's if you have a rupture. So the goal then is to prevent the aneurysm from rupturing. So one of the ways that we do that is we try and focus on early detection. We get prompt service. Treatment is imperative. Once it's detected, we need to do studies to see its size and its location. So depending upon its size, it's kind of going to tell us what our interventions are going to be. And these are all interdisciplinary, interprofessional interventions. So if you have a small aneurysm, less than 5.4 centimeters, we're going to be using conservative therapy. This is where my mother-in-law is, in case you're wondering about where she was at in terms of her stuff. Hers is like 3 centimeters. So we're going to be working on risk factor modification, such as, sorry about that, lowering the blood pressure. High blood pressure is going to stress out that aorta even more. Tobacco cessation. Those carcinogens that are flowing through the body damage the arteries anyway, and then you've got an already damaged artery that has an aneurysm and a bulge, and then hopefully by quitting the smoking, we can help stop further damage from occurring. Optimize lipid profile. So we're going to take a look at those lipid profiles that we've been looking at for coronary artery as well, and gradually increasing physical activity. If you have somebody who has a 4 to 5.5 or a 4 to 5.4 centimeter, they'll be getting monitored every 6 to 12 months with an ultrasound, with a CT scan. If you have it less than 4, alligators eating the bigger part. If you have it less than 4, then you'll have an ultrasound every 3 years. If you have a bigger one than 5.5, because 5.5 is kind of the cutoff. So if you have a bigger one than 5.5, then we are going to be taking a look at doing surgical repair. Surgery may occur earlier in patients that have some type of genetic disorder. Perhaps they have a genetic disorder that's creating some sort of frail vessel things. If they have a rapidly expanding aneurysm, if they have symptoms, if they're a high rupture risk, like they won't quit smoking. I had a AAA patient that we did a AAA stent on him, and he went into the bathroom and had a cigarette on the day of discharge. Like, you've got discharge orders. I'm just working on putting together your patient education packet. Keep your pan out of the bathroom smoking. That was a frustrating day. He ended up calling me Nurse Ratchet by the end of the day, but I think it was justified. So, high rupture risk. He didn't realize that I was advocating on behalf of his health against his actual addiction, which that happens. So, and then identifying and correcting any comorbidities. If those comorbidities can drive up your surgical interventions as well. These two pictures come from the book. This is figure 37-6. This is an open surgical repair where we actually would cut the whole belly open and to put in that sleeve in that stented sleeve. More often than not, people are going to be using a femoral approach. And that femoral approach, because there's less stuff, because we have to go through the skin, the fat, the peritoneum, and then through the guts to be able to get to the aorta. So there's a lot of stuff to get out of the way if you're doing an open surgery. If you're doing a femoral approach surgery, it's a lot easier to get to it because the femoral arteries are a lot easier access, and we don't have to move your guts around to be able to do that. So figure, and we had seen this figure when we were talking about atherosclerosis in general. This is an example of a femoral approach stenting for a AAA in figure 37-7. So here are some questions that I was going to pose. Here are some questions that you should be looking up if you are, when you're listening to this, to be able to do a short makeup session from what we ran out of time for the other day. And I basically just gave you the answers to this particular question, which is the most invasive, open, or femoral, and then why. Here's what I would like you to either investigate and or think about on your own, and or get together with your study buddies and discuss how the post-surgical care of these clients would be similar and how would it be different. Like, what would you be expecting to do as far as your assessments and things that you're going to be looking out for? How would they be different as well? I'm going to stop sharing. This is my makeup catch up sort of on aortic aneurysm. I'm sorry we didn't have a chance to get to it the other day, but I'm glad that I had a chance to record it for you today. And I will be posting this as soon as possible. Have a great weekend if you're watching this on Friday when I post it. Otherwise, I'll see you in class, and feel free to bring any questions that you have along with. Okay.